Good evening, everyone. Welcome to our webinar on COVID-19. Appreciate everyone signing on tonight. We've got Dr. Harris, our state health officer, with us to give us an update on where we are with vaccines and COVID-19. I would remind folks that on this webinar, if you have a question, it'll work best if you'll do that through the chat function. And that way, when we get down to the Q&A session, that'll already be there, and we can handle the questions that way. So you don't even have to wait for the Q&A session. You can go ahead and put your question in the chat, and we'll be able to get to it that way. And I'll remind folks that join later. But I'll quit talking, and Dr. Harris, let you get us up to date on where we are with COVID-19 and vaccines.
Sure. Well, thank you very much, Dr. Meggs, and thanks for having me again. I always enjoy these talks very much, and it's good to be with you. I'll just try to do like we always do. I'll just kind of give you a brief overview and just sort of update you on the status, and I'll try to mention a few things that I'm sure you'll be interested in, and then we'll be more than happy to take questions and cover whatever else you would like. As you know, we still continue to see cases each day, and from most counties each day, although our numbers are a little bit better over the past 3 weeks or so, almost 4 weeks or so. Alabama still is just under 500,000 total cases. That's total unique individuals since this began just a little over 11 months ago. That represents almost 10,000 deaths, unfortunately about 45,000 hospitalizations. All that said, we have seen some improvement since about the third week of January. January was a really difficult month for us in terms of deaths. We set new records in terms of the number of deaths that we've seen. In fact, really, more than half and somewhere around 60% of all the deaths that we have seen have occurred just in the last 3 months, just since Thanksgiving. So it has been a very difficult fall, but difficult autumn, but we feel like we are improving just a little bit since that time. Certainly having, more than 10% of our population actually infected at some point, certainly probably conveys immunity to many of them. Certainly many of those who were recently infected have some immunity. The vaccine effort has vaccinated more than 10%, actually more than 11% of our state with at least one shot as well. And so I think both of those situations contribute a little bit to the numbers falling. I think just getting past the holidays itself certainly plays a role too, with hopefully less gatherings than we would see during the actual holiday time. The vaccine rollout continues, and we actually are very proud of where we've been over the past 5 weeks. We clearly got off to a slow start, and that was unfortunate. But for the past 5 weeks, we've given everything we've received. We've had well over 100,000 doses each week. We had 2 weeks ago more than 150,000 doses, almost 160,000 doses we were able to give out. This past week, even with all the weather setbacks that we had around the state, in the north and northwest particularly, was our second best week for vaccine administration. We gave out over 125,000, almost 130,000 doses. And so we are getting right now around 80 to 85,000 first doses a week, or that's what we'll start this coming week with, around a similar number of second doses. So it's difficult to give more than about 150 or 160,000 doses in a week. And we feel like we're doing a very good job with that. As you know, we have now expanded our eligibility categories, not just to healthcare workers and nursing home residents in the 1A category, but also to all persons 65 of age and up, as well as everyone in the 1B category. And the 1B category includes educators, it includes corrections workers, it includes certain manufacturers, it includes food and ag workers, grocery and agricultural workers. It includes some others, including first responders as well. So all in total, that eligible group is about 1.5 million people. We advanced to include those eligible groups for a lot of different reasons, but it certainly wasn't it wasn't because we had plenty of vaccine to give them. Again, those 1.5 million people need about 3 million doses for us to cover them, and we're still getting somewhere around 80,000 doses per week, first doses per week. So it continues to be a challenge. I know many of you on the phone are involved in this effort. Many of you would like to be involved in this effort. We have now around 1,100 providers around the state who are fully enrolled and validated and ready to go. We have hundreds of others who have sought to enroll and just have not yet been fully validated and brought on board, because we have enough vaccine to send to around 360 or 370 providers each week. So in any given week, more than 2/3 of all the providers who are ready to go at the drop of a hat are not going to be able to see any vaccine. So we hope that we'll see some improvement. Our Moderna and Pfizer allocations are increasing a little bit, 2 or 3% per week. It turns out that Pfizer actually is able to ramp up their manufacturing a little bit more than we had thought, and a little bit faster than Moderna. I think originally we thought it possible that maybe Pfizer would just be a bridge to get us to all these other products that didn't have such a stringent cold chain requirements, or maybe to the one-shot vaccines, or to other products. But in fact, Pfizer has ramped up their production really well. A lot of that product is being taken for some of these federal efforts, including the federal retail pharmacy program and the federal long-term care program. But yet we're still getting Pfizer, and are looking for ways to spread that out among providers. We do have more and more providers coming on board who can handle the Pfizer product now, that, and we expect Pfizer to say something definitively soon about some reduced requirements in terms of cold chain. There probably is a vaccine that can last in the refrigerator for a while, certainly much more than we have been able to say before. So that will certainly help. As we have expanded our eligibility, we're changing a little bit how we allocate vaccine and where we send it. And we've talked about this many times on these calls, but it's really difficult for the public to understand sometimes. We send vaccine around the state based on the eligible population. It's not based on the total population. It's not that the biggest county gets the most doses. It's based on where the eligible population lives. When we were only targeting healthcare workers, those people don't tend to be evenly distributed in the state. They're clustered in certain areas, and so more vaccine was going to certain areas. Now that we've added this 1B population with people like educators and grocery and food and ag and so on, we see that those people are a little more evenly distributed around the state, and that's going to make a difference in how we allocate. At the same time, we also still care very much about equity. We still very much care about protecting the most vulnerable people with this vaccine. And so some of our Black Belt counties in particular have a real lack of access to care, have a real lack of providers, even in those who have some kind of insurance. We're trying to make sure that we prioritize those counties and make sure that we're covering them adequately, even though overall our strategy is to give vaccine based on eligible population. So I'll mention the Johnson & Johnson vaccine, or the Janssen vaccine. Janssen, as you know, is a Belgian company that makes this vaccine. They're owned by Johnson & Johnson, and so sometimes you hear it referred to as one or the other. The Johnson & Johnson vaccine, we think we will know something by the end of the week about it becoming available. All signs point to it being granted authorization by the FDA by Friday. The ACIP, which helps make the recommendations on how that vaccine is actually used to CDC, is meeting on either Friday or Saturday. And so we think CDC will speak to that probably Sunday or Monday, and then we'll know when we're going to get that product. J&J did not ramp up their production at the same rate as Moderna and Pfizer had done. But we did hear today that there may be as many as 20 million doses available, ready to ship pretty soon. So that would certainly substantially augment the supplies that we have in the state so far, and that's very encouraging for us. Just a couple of other items. The current health order expires a week from this Friday on March the 5th. So we're in talks with the governor's office now about what to do next. All indication is that they remain supportive of our face covering mandate. We greatly appreciate their support, and and don't know for sure, but believe that they'll continue to support that. That's probably the major issue to be talked about. There's still a lot of discussion, and we hear a lot from people over visitation in healthcare facilities, especially nursing homes. Even though it is technically allowed at this point, there's still some issues to be worked out there. Senior centers in particular have been closed since March, other than for takeout meals, and so we've got a lot of we've had a lot of discussions with Department of Senior Services over whether there's any way to address that situation, because that's such an important part of life for many seniors, and especially in rural areas where they don't have access to a lot of other services in some cases. So I'll just pause right there, Dr. Meggs. That was pretty quick and didn't cover a lot of things there, but I know there's a lot of things people would like to talk about, and I'll be glad to try to answer questions.
Do you see the questions on the chat, or if not, I can.
Let's see. Oh yeah, let's see. I believe I do here. Let me just pull them up, and I think I can see them.
And I would remind folks, if they've got a question, if they'll put them in through chat, we can get to them as we can. So I know that first one from Tyler up there about federal supply.
Sure. Yeah. Okay. I see them here, Dr. Meggs. Let me address those. The first question says, if there is a surplus of doses at the federal level to allow distribution to Walmart, et cetera, why does the state have difficulty getting enough doses to satisfy current approved eligible populations? The answer is all states are receiving a per capita allotment. So Alabama is about 1.5% of the United States based on population. We get about 1.5% of all the vaccine that's made available to the states, but there is just a whole group that skimmed off the top at the federal level before we ever get the pool made available to states. As you know, the federal government vaccinates, Department of Defense, and they vaccinate certain groups of federal employees. And they have also developed this long-term care, the retail pharmacy program. They've just announced a program with community health centers, FQHCs. All those are the federal allotment that skimmed off the top before the allotment is divided up for states. It's a zero-sum game, and if the feds weren't taking anything off the top at all, then we would have more coming in. And yet, this program also vaccinates people in our state that we don't have to vaccinate with our state allotment. So it's kind of a wash for us. The next question says, if an individual has completed a vaccination series by at least 1 month and has no symptoms or fever, what is the likelihood that individual could transmit COVID to another individual? I think certainly people are at risk to become infected. As you know, that's something that you all understand on this call that the public doesn't grasp quite as easily. But these vaccines are more than 90% effective, which makes them incredibly effective vaccines, but they're certainly not 100% effective. People can become infected. They probably don't, maybe in most cases, get as sick. They're probably less likely to have severe complications. In terms of transmission to others, I don't know the answer to that. I see Mike Saag on the call, and he may be better able to speak to that. Mike, if you don't mind me calling on you, would you be able to address that question?
Sure. The answer, bottom line, is that nobody knows for sure. But the hypothetical concern is that while these vaccines are 90% effective, what they're 90% effective at is preventing symptoms. So that doesn't mean that person couldn't become infected, be asymptomatic, and then unwittingly be transmitting virus, although I'm sure at a much lower inoculum, that is, they're spewing out, if you will, less virus. But the concern is that they could be. So when people think about getting together again, if you know for sure people in your immediate environment have all been vaccinated, then I think you're okay. But if you're in a group or a crowd and you don't know what the other folks' situation is, then we should still be wearing masks for at least the next couple months, in my opinion.
Good. Thank you for that. The next question, this would also be a great question for Mike, which says, is there any data that shows the vaccines induce a T-cell response in addition to an antibody response? I assume there is, but can you speak to that, Mike?
There are responses across both T-cell and B-cell immunity. What's interesting is that we're finding that people who have had active COVID disease, as we know, we want to wait about 90 days as a recommendation until they had COVID disease, wait 90 days for their vaccination. And their responses seem to be better, as you might guess, than those people who've never had COVID before. But right now the recommendations are to wait that time, but the immunity is pretty robust.
Thank you for that. The next question says, what are the criteria for lifting all COVID restrictions? I think there are some restrictions that are going to be with us for a while. The real answer is when we see a reduced disease transmission. You know, it's not necessarily a particular vaccination percentage threshold. It's when we see disease transmission going down. If we have community transmission going on in every county, which we still do at this point, your most vulnerable people are going to be at risk. And so I think some things like face masks or hand washing or even social distancing, symptom checking when you have groups of people together, those are things that are going to be with us for a while, even if they're not mandated. I think they make a lot of sense. I don't think we expect COVID-19 to disappear completely. So hopefully some of these things, even if they're not actually mandates, will be with us for a while. The next question says, thank you for the monoclonal antibody webinar. I found the monoclonal infusions to be very helpful. From what I can understand from the webinar, it is acceptable to use hydroxychloroquine, ivermectin, vitamin C, etc., adjunctive to IV monoclonal antibodies. And hydroxychloroquine and ivermectin can be used for those who don't qualify for the infusion. This seems appropriate since these measures have large numbers of studies, including randomized clinical trials, show they are effective. Are there any reasons we can't use these? I would, sort of take issue with that. I don't believe randomized clinical trials have shown they're effective. We've had this discussion many times with people over the past few months. I know several months ago, there were a lot of studies underway, and we were waiting to see how those studies turned out. I think I would just refer you, just as a starter, the Mayo Clinic and others did a terrific meta-analysis that was published in, I think it was about October, in the Journal of Antimicrobial Chemotherapy. They looked at all the randomized clinical trials. They looked at all the big cohort trials. They selected trials that looked like good data and not case reports and not just anecdotal kind of observational studies. And there's, good evidence to say a lot of things, which is we don't think hydroxychloroquine prevents mortality and improves mortality in hospitalized patients. It doesn't seem to improve hospital course in hospitalized patients. It does not seem to prevent infection in people who are close contacts and then put on it. And it doesn't seem to keep people who are infected out of the hospital. I think all of those are studies that are from really well-designed studies. And I personally don't recommend using it, and don't, we certainly in public health don't regulate physicians' practices and tell you what to do. My view is that there's not good evidence for use of hydroxychloroquine in particular. The next question is, if our pulmonary office has been approved to give the vaccine and we are placing orders for the vaccine but not getting shipments, what do you suggest? Certainly contact us if you think you should be getting one. I will tell you again that I pulled some numbers today before I came in. At this point, we have, this was as of Monday, we have about 305 physician offices that have been fully approved and verified, have their freezer capacity verified, and about 106 of them, so right at a third of them, are able to receive vaccine because we just don't have enough to go around. As we get additional supply, certainly more providers are going to be included. As we move the vaccine around to different parts of the state, because we're trying to reach different counties and their eligible populations, that will pick up some people. But generally speaking, we just don't have enough right now to. But if in particular, if you have been expecting a shipment that hasn't arrived and you know that something's coming and haven't received it, please reach out to us on that. What are your recommendations for second doses in individuals that have had COVID? Certainly, previous infection is not a contraindication to being vaccinated. Just like any other person receiving any other vaccine, you want that person to be afebrile and well and otherwise a candidate to be vaccinated. But if they're beyond their period of isolation and they're no longer having symptoms and they're otherwise eligible to be vaccinated, then they certainly can be vaccinated. That applies for first doses as well, for initiation of the vaccination regimen. We have put out just sort of, general guidance which suggests if you've been recently infected with COVID-19, you probably do have some immunity on board for a while. And we've asked people to wait 3 months or so just to give up your place in line to somebody who doesn't have any immunity on board. But certainly there's no contraindication to being vaccinated if you've been infected. And I'll just say to Mike, jump in here anytime if you have anything to add on that. So let's see. Have there been any studies to quantify what percentage of Alabama have actually had COVID and perhaps not been formally tested, say by Red Cross or blood donations? Yes, there are actually two studies on that. CDC is doing serology surveillance. They are actually collecting blood samples that are submitted to commercial labs for diagnoses other than COVID. And they're doing testing on those samples to see, and we have been somewhere north of 10%, not a lot higher than that, but 10 to 12% are the numbers we've seen from that study, which is means we're not missing maybe as many as we think. The Red Cross is also doing that on blood donations. They've had some numbers that have been a little higher. I've seen numbers on the Red Cross that put us between 15 and 20% seroprevalence. But both of those things continue to be done. They're not necessarily large surveys, but they do give you some pretty interesting information. The next question says, why is Alabama number 50 in the nation in percentage of residents vaccinated? Hey, we made it to 42 today, actually. We certainly could be doing a better job, and we'd like to improve, but we got off to a slow start. There are a number of reasons for that, and all those aren't necessarily unique to Alabama, but occurring as it did during the holiday season, with our first doses going to a Pfizer vaccine going to a really small number of facilities simply because of the cold chain requirements. It's just taken us a while to ramp up. But as I mentioned to you earlier, for the last 5 weeks, we've given everything we've given. I think that means we have to be tied for first over the past 5 weeks because we can't give out more than we've given. So it's just hard when you start from behind to catch up. So we are continuing to do the best we can. 50th is certainly not good enough, or 42nd for that matter. The next question says, the latest CDC guidelines, as I understand, give 3 months of antibody immunity, at least the time frame where one would need to return to quarantine. What's the thought on revaccinations? So if I understand that, I think we believe that people who are fully vaccinated and have been more than a couple of weeks after being fully vaccinated, we don't suggest that they be quarantined if they are exposed to someone as a close contact. The actual guidance on CDC on that says that within 3 months of completing a vaccination, they don't have to be quarantined. And that's because that's just all the data we have right now. The vaccines haven't been around long enough. Presumably, I think most of us think the immunity is going to be a lot longer than 3 months. But in terms of when you have to be revaccinated, time's just going to have to tell us that. We just don't know yet. And I think it's going to be a lot more than 3 months, but we just don't know yet. The next question is the J&J vaccine less effective? The answer is, if you look at overall efficacy in the United States, it was about 72 or 73% effective compared to low 90s for the other two vaccines. However, when you look at preventing serious illness and hospitalization or preventing deaths, it was identical to the other two vaccines. In terms of preventing the things we're really worried about, serious illness and death, it was equally effective. This is a really important message for us to get out to the public, because we don't want to create some hierarchy system where people want to pick and choose a vaccine because they think one's high quality and one's low quality. Well, I really hope that I can convince all of you on this call to carry that message out to your patients, to folks in your community. This is a great vaccine, and the vaccine you ought to take is the one that you have made available to you, whichever one that is. And it's just because we have such a scarcity right now. Please take the vaccine that's available. There's no reason to think that J&J is an inferior vaccine or one that shouldn't be used. It's also one shot, as Mike mentioned earlier, which is great. It's also much easier to handle in terms of cold chain. I think we're looking for sort of unique ways we can use it when we think about going out to reach homebound populations, for example, where it's really labor intensive and you have to travel to one site to vaccinate one person. J&J makes great sense in that setting. In my view, you don't have to worry about refrigeration. You don't have to worry about, wasting a whole vial. You just take one shot to one person and don't have to come back. And so that seems like a great niche for that. And maybe for mass clinics too. Mass clinics are so logistically challenging anyway. Being able to give a one-shot vaccine and not having to do it all over again in 3 or 4 weeks may be a good place for J&J as well. The next question says, I have patients who are not currently in any of the eligible categories, but have some underlying condition, for example, 42-year-old with asthma or lupus, who are asking if they can get a letter to get the vaccine. I do not believe this is an option in our state, but can you please confirm? I would say, unfortunately, they're not eligible at this time. It's a rationing kind of decision. It's not fair. And of course, everybody deserves to get vaccinated. We want everyone to get vaccinated. People with chronic health problems certainly are at high risk for complications. But also, because Alabama is at baseline a pretty unhealthy state to begin with, once we drop down to 1C and pick up that group of people that have chronic health problems, we're going to more than double the eligible population. There are more people in that group than we have in our entire group right now, going through phase 1A and phase 1B and adding the 65 and up people. The people that have diabetes and heart disease and all those things that Alabama has in abundance is a huge number of people, and they absolutely deserve to be vaccinated. But we have just not included them at this point because it doesn't seem right to announce to all these people that they're at the front of the line when there's no vaccine to give them. So
let me jump in real quick, if I can. There may be some nuggets of really good news in today's news, where Pfizer and Moderna went apparently to lawmakers today on a national level and announced that there's going to be up to 440 million new available doses to the states or at least to the government to be distributed over the next 5 weeks. Now that sounds almost miraculous, but if that's true, that could speed things up dramatically, because at that 1.5%, 1.5% of 140 million is a lot. It's like 1.5 million or more by the time it gets to us. So that with the 20 million J&J vaccines, hopefully, maybe by mid-April, a lot of these questions about who's eligible will become moot, and we're going to be moving forward vaccinating as many people as we can. So we'll see, but that's encouraging.
Yeah, thank you very much for that, Dr. Saag. That is very encouraging. The next question says, I keep reading about several FDA-approved home COVID tests. Any ideas when these will be available? I have to be honest, I don't know the answer to that. I don't know if anyone else on the call knows that, but I'm not aware of the timetable on that. The next question says, for patients that do not meet bamlanivimab criteria and have continued shortness of breath without depressed SpO2, are there medications, that inhalers or oral medications, that are recommended? I'm going to ask Mike if he knows the answer to that as well. He's got a lot more expertise in that than I do.
Right. So a lot of times I think an inhaled steroid really helps in that situation. Also, the use of bronchodilators is what we commonly use. And I think those are our best choices there. If, as the disease progresses out, and let's say they're deteriorating some, not quite needing hospitalization, and we're beyond day 8, then you might start thinking about systemic corticosteroids. But please don't use that too early, because it interferes with the interferon response and can prolong the illness. So after day 8, from onset of symptoms, and let's say especially they're moving into day 10 or 11, they're not really getting better, that's when you might pull the trigger on systemic steroids, but only in that situation. But before then, inhaled steroids are quite effective.
Great, thank you. I'm really glad you're on this call, Mike. That's terrific. Next question is, what do you think about the new studies that show in vitro that Pfizer and Moderna vaccine is 67 and 83% less effective, respectively, to the South African strain? I have not seen that study, but I know there certainly are some concerns about South African strain. The UK variant seems to be well covered. My understanding is that there's still being work done to determine whether either the South African strain or the Brazilian variant need additional products or additional doses. So that's all that I'm aware of on that one.
Moderna's already created a candidate vaccine that they're now testing with the South African strain as the active spike protein mRNA. So if we need to get to a booster, it's already in development. So that's good news.
Yeah, great. The next question said, did you state you wanted providers to reach out to ADPH if they're expecting the COVID vaccine but haven't received it? Yeah, what I was actually referring to is if you know that you have a shipment coming that has not arrived because we've had weather concerns, please let us know about that. I think we know about those and are tracking those. If you're someone who signed up for the program and you're eligible but have never received it and have never been notified that you're going to receive it, certainly you're always welcome to reach out to us, but in almost all those cases, we just don't have vaccine to send right now. Again, more than 2/3 of folks in that situation have never yet gotten any vaccine because we just don't have enough to distribute at this point. We really hope that's going to change very soon as we see these other products. At the current allocation rate allowing for weekly increases, how long do you think it will take to fully vaccinate all the people in the eligible category? That's actually a pretty straightforward math problem, and it's terrifying. We hope to eventually get to 4 million or so people in our state. That's 8 million doses. That's going to take about 2 years at the current rate. However, we know, first of all, uptake's not going to be 100%. We'll be fortunate in some groups to get 50% uptake. So we're never going to reach a lot of the people, even though they may be in an eligible category. Also, we think we're going to continue to see new products. And I think we're certainly waiting to hear about AstraZeneca, waiting to hear about Novavax. By the summer, it's reasonable to think we might have 5 different products available. And then there are others. I mean, there are still others under development. So I think that we would like to believe that by the end of summer or by fall, we can have some sense of, anybody who wants a vaccine can go and get one. What we hope is that we have covered enough of the eligible people that we don't continue to have a lot of disease going on. We hope there aren't people who are unwilling to take the vaccine that we haven't been able to convince.
And also my guess is that by May, the pediatric studies will be coming to fruition. So we'll know what to do in children under the age of 16. So stay tuned for that.
Yeah, thank you. The next question says, is anyone in Alabama conducting studies on the antibody response after 1 vaccine in younger age groups to decide if certain groups need 2 versus 1? I don't know if that study is being done here. Mike, do you know?
There is a pediatric study. I don't know if it's asking that precise question. Sorry, I can't help. But I know there's studies underway, as I alluded to, that I think will be coming to fruition. I don't know how much the 2 versus 1 is being evaluated.
Sure. Next says, will we have to take vaccines yearly with 3 to 4 mutant strains like flu has 3 strains? I think, certainly that's a reasonable thing to think about, but we don't know. I think we don't have the answer at this point. Next says, do you have any guess of percentage of Alabama population choosing not to get vaccinated? I would say it depends on the group that you're talking about. In our nursing home residents right now, because they are confined and we can easily get to them, and we have a federal program that's supplying the vaccine. Uptake in that group has been really good. It's approaching 90%, and may even end up being a little bit higher. By comparison, just for example, nursing home staff, much, much, much lower. In many facilities, it's going to be more like 25 to 30%. I think facilities are really thrilled if they feel like they can get half of their staff to agree to the vaccine. And so it really just depends on which eligible group you're talking about. There's vaccine hesitancy, as you know, out there for a lot of different reasons. It's important to remember that vaccine hesitancy is, that's not a big monolithic group of people who all have the same beliefs. A lot of vaccine hesitancy is just normal and makes sense, and it's just smart people asking good questions, and we just have to be able to get them the right information. You know, if you're somebody who's medically literate and you have a computer and you have a doctor that you can ask questions to, a lot of your questions are going to get answered really quickly. But we have a lot of people in Alabama that just don't have those advantages. And so they have very reasonable questions about, is this safe, or do I really need it, or is it worth it? And they just don't have anybody to answer those questions for them. So we're working very hard to address hesitancy for those reasons. Certainly, there's a lot of historical reasons that there may be mistrust among African American communities about public health and our vaccination efforts, and that's a story that everybody knows very well. We're working very hard with through a number of channels to try to address that as well. So again, I think it just depends on your group. The overall uptake among physicians was really, really good. The overall uptake among most hospital employees was quite good. Nursing home workers, not so much. The overall uptake among people over 75 has been really, really good. We've already vaccinated more than half of all the people age 75 in our state, and still have a lot of demand. So it just really depends on your group. The next question says, primary care physicians have been educating and giving patients about vaccines for years. We are able to give vaccines at this point. We feel very forgotten and underutilized. To vaccinate the state, you will need all hands on deck. What are you going to do to reach out to primary care physicians to regain their trust? That's a great point. We absolutely do need all primary care physicians to be involved. Our vision for this vaccination program is for everyone in Alabama to be able to go get a shot from the same place they get all of their other medical care. And that might be their doctor's office. It might be their community health center. It might be an urgent care. Some people go to the pharmacy to get a vaccine. There are other places that we can do that, and we need everyone to do that. This will become a routine part of primary care. Certainly, if there's a need for booster doses, this is going to be a routine part of primary care at some point. So we absolutely want to work with primary care physicians, make sure that we really do need you and want you to be part of the program. Please enroll in the vaccine program if you have not done that yet. I know people are frustrated because there's just not enough vaccine to spread around right now, but very, very, very soon, in the next couple of months, I think there is going to be. So please hang in there. Thank you for your patience, and we're going to make sure you're included, because we actually have to have primary care on board if we're going to get this done. The next question says, is there ongoing collection of data from the now millions of vaccinated people related to side effects that are published anywhere? I'm not sure what's available, but the answer is absolutely yes. First of all, the drug companies that are introducing these continue to collect data on that nonstop, and they're continuing to follow this up. Also, as you know, CDC separately collects data on any type of adverse events. They have that available as well. I don't know about the publication status of it at this point.
There was a paper that just came out today in a preprint from Scotland, where they have vaccinated almost 99% of their population, and they're not seeing anything new in the way of side effects. What they were looking at was a single dose and a delay of more than the 4 weeks, and they found that the antibodies peaked at about week 6, and then they started to decline. And so the notion of that question of, can we give one dose and then skip the second dose for a while? It appears that you might get an extra couple of weeks out of it, but it doesn't look like it's a fabulous long-term strategy, at least with the Pfizer vaccine.
That's good to know. Thank you. Let's see, I see a few other questions here that have popped up in the Q&A part. One says, have any of the variant-infected patients been hospitalized anywhere in Alabama yet? If so, how are they doing? What is their hospital course? I would say the numbers are so small, we wouldn't normally speak about a specific patient and what happened to them. But the answer to the first question is yes, there have been patients hospitalized in Alabama. And that's, I don't know a lot more than that off the top of my head, but just because there's only 22 patients so far, I think that's probably all I ought to say about that. Do you anticipate a change in the policy that fully vaccinated people have to be screened prior to return travel to the U.S. and have mandatory quarantine upon return? The answer is I don't know. I don't know what the policy is going to look like on that, or what anticipated changes are. We have, through our public health associations, regular calls with the White House and with HHS, and we have not had any input sought from us on that topic. The next question says, when you say we should contact someone if we ordered vaccine and are still waiting, who exactly should I contact? I applied and was approved in early December, place order the next week. I'm rural, serving many small towns. Vaccines are new to me. I've been an imprint provider for 11 years, and no one can give me an answer where I am in the wait list. If I'm far down, why? I won't argue. I'd just like to know why the pharmacy in my town has vaccine and I don't. Yeah, I certainly understand what you're saying. We don't necessarily have a list of who we go to in what order. That changes a little bit depending on which patients we've reached and which patients we need to continue to reach. We again are only able to send vaccine at most to about 1/3 of the providers in the state in any given week. When we vaccinate a lot in one area, people understandably expect that they're going to, if they do a good job vaccinating, they're going to continue to get product. That makes perfect sense, except that in a lot of cases, we then need to address other parts in the state where we haven't had as much vaccination going on. And so I know it's irregular delivery schedule. I know people are very frustrated with that. I'll tell you, we're very frustrated with that as well. But we, again, in the next few weeks are going to have a lot more product available, I think, and we're going to be able to reach a lot more people. So thank you for your patience on that, and we will do our best to get it to you as soon as possible. The next question by the same person says, the pharmacy in my small town gave some of my staff vaccine, and I was seriously concerned about placement. If the needle were long enough, it would have gone in their joint. I love the PharmDs in my community, but it is insulting that I can't vaccinate, and some of them are using improper technique. I certainly hear you and understand what you're saying. We will do our best to get vaccine to you as soon as we possibly can. The next question says, why does Walmart and other pharmacies receive the vaccines before physician offices? That is not a decision by the state. That's part of the federal retail pharmacy program. The federal government has contracted with about 22 pharmacy chains around the country, different ones in different states, depending on what chains are available in a given state. Because CVS and Walgreens were part of the long-term care pharmacy program and were vaccinating nursing homes, the federal government selected Walmart in Alabama, and those stores are being supplied with a federal allocation. It does not come out of our state allocation. I can tell you the first 74 stores, we didn't even know they were coming until they were here. We had no input on that whatsoever. Walmart has announced they're about to add 18 more. And so even though we weren't asked for input, we gave them input. Anyway, we called them, we asked for a call. We identified for them the parts in our state, the places in our state where we felt like we had gaps. And they've been fairly responsive. And I think they're gonna try to place it in some more stores to help us address our equity goals in particular. Ultimately, their plan is, and I think they'll do this soon, is to have it in every one of their stores. I think they have just under 150 stores, and the plan is to have it in all of them. Again, the point is that does not take away from what our state allocation is. The feds told us on Monday they plan to add a second drugstore chain. I don't know for certain which one it is, but there'll be another chain pharmacy that's going to be part of the federal program that we should learn about next week as well. So this being Alabama, it'll be CVS or Walgreens, but I don't know for sure. The next question says, I read about a protein-based vaccine versus mRNA vaccine being tested. Any new information? You know, the next vaccine to be authorized is going to be Janssen or J&J. That vaccine is, you know, uses an adenovirus as the way of introducing material into cells to generate an immune response. The next one that you may be referring to is Novavax. Novavax is actually a subunit vaccine. You know, subunit vaccines are what we all had our whole life. It's the technology that we, I guess, know the most about. They generally are safe, and they're oftentimes very effective, except sometimes you have to have adjuvant with them. But that may be what you're referring to. I think Novavax in the long run will be a vaccine that hangs around because we just know so much about subunit vaccines, and they're pretty easy to handle, and they're slower to make. It takes a while, and that's why it's coming out a little later. The next question says, if a patient has received the first dose of vaccine and then tests positive for COVID a few days later, when can they get the second dose? If they receive the monoclonal treatment at this point, do you delay a second dose by 3 months? I'll ask Mike to help me with that, but I'll just say we sort of addressed that earlier. If someone's infected and they're well and beyond their isolation period and otherwise eligible for vaccination, they can be vaccinated. CDC now has said the data on second doses is that waiting up to 6 weeks is acceptable. It's not preferred, but we can certainly wait up to 6 weeks without concern. If I could ask Dr. Saag to talk about vaccination after monoclonal antibodies.
Yeah, so this question must come from somebody who's hanging around with me in the monoclonal antibody clinic, because we see a couple of folks just like this every week in our monoclonal antibody clinic. So it's somebody who got a vaccine, their first dose, and then day 4 or 5 gets sick, and they aren't sure if it's from the vaccine or whether it's an infection. You test them, it's truly an infection, give a monoclonal antibody. We're recommending to wait another 2 to 3 months before they get the second dose. And I think that's fine. They had the prime of their immune system with the first dose. They got, in essence, a little bit of a booster early from the actual infection, and then boost them again a couple months later. I think that works.
Good, thank you. Let's see, I see one more here that says, any thoughts as to when the state may move to 1C? Yeah, we sort of mentioned that earlier. I think it really depends on uptake, and it really depends on, with the group we have now, and it also depends on what new products we have there. I think it's likely that sometime, in the summer, maybe late summer, maybe midsummer, we'll probably be almost wide open, almost phase 2. But again, we're going to continue to stay with the phase we have as long as we're giving out all the doses we have every week. When it looks like there may be some declining uptake, or when we get a whole lot more vaccine available, is when we'll move forward.
Scott, that looks like all the questions. You've done a yeoman's job tackling that. We appreciate it. And again, on behalf of the Medical Association, I want to thank Dr. Harris and Dr. Saag for being with us tonight, and thank all the participants for your interest and your questions. I think some of this stuff we go over every time, but I think it takes a little bit to drill it into some of our hard heads, but we do appreciate the information and your willingness to be available to us. And we may need to do this again in a few weeks. But thanks again. Appreciate everybody's participation tonight, and everybody stay safe.
Thank you very much. Thank you.